Hi everyone, and this is exactly where we left off in our last lecture. So as we can see here, this is a mid-sagittal view and an MRI of our foot and our ankle. So what I had asked everyone to do is to identify each of the structures. So I'm going to go ahead and reveal each of the structures now. So what I want you to do is take a look at all these. Take a look at exactly, what you have identified correctly, what you have not identified correctly, and I really want you to study this material in depth because obviously we're going to have a few test questions on this. And we're going to have a lot of labeling on the final exam. So I want to make sure that everyone's very comfortable with labeling on the final exam. Obviously, we're going to do a Blackboard Collaborate session here next week, and I will post some pictures on there. We'll do some labeling, we'll do some identification on top of some clinical application and integration as well. So this is a little different view of the foot, and obviously what we see here is we see a mid-tarsal view and a metatarsal view in the A, B, C, and D slides. And the E slide really gives us a nice view of the plantar surface of the ankle, or I'm sorry, not the ankle, the foot. So, really what I want you to do here is take a look at this, take a look and really appreciate the amount of detail, and then start thinking about what structures could be involved and then how your patient would present with those sorts of structures, or I'm sorry, with those sorts of symptoms. So now we're going to get into a little bit of the pathology. So again, when we're looking at ankle and foot, nothing changes from the start of the semester. We're going to do our ABCs. We're going to look at all the joints. We're going to look at all the alignment. We're going to look at all the bone density and the cartilage and everything that we have already talked about. So specific to the ankle joint itself, you're going to see a couple different pointed out structures here in the image. So we have the actual ankle joints. Typically, we want to see about 3 to 4 millimeters in width. Remember that mortise view is going to give you the best view of that actual mortise joint. There's a medial clear space, which is what is denoted by MCS on the label. That's about 3 to 4 millimeters. And there's also a lateral clear space, which is about 5 millimeters. Now, obviously, if we have anything over those amounts, then we're going to start thinking about things like maybe a high ankle sprain, maybe an anterior talofibular ligament disruption, or some other obvious abnormalities that can happen. But to give you a sense of what the normal is, that's exactly what the normals are going to look like. So taking a look at this picture here, again, we can see both the proximal and the distal fibula here. We can see the proximal and distal tibial-femoral interfaces or joints or articulating surfaces. So we need to make sure we can tell and identify each of those structures and what is abnormal and what is normal, obviously. Taking a look at this picture, now this gives you a really good idea of why we want to do more than one view. Obviously, the picture on the left, we really don't see much of a fracture line at all. But we turn that leg, if you will, and we do more of a lateral or oblique view, and we have a much different picture. This is obviously due to X-ray attenuation. You can see a little bit of the fracture line once you really look for it, just distal to the tibial tuberosity. But obviously, when we do that lateral view, you can see a much better fracture line. And obviously, as the title shows, this is a non-displaced fracture of the proximal tibia. So getting into malleolar fractures, you're going to see different malleolar fractures in radiologist reports. You're going to see something called a unimalleolar fracture, a bimalleolar fracture, or a trimalleolar fracture. Now this gets a little confusing because, obviously you think about it, we have two malleoli. So, to start off with, really you should kind of think about why do we have a trimalleolar fracture? That doesn't seem like it should or could exist. So what I want you to do is really just kind of think of unimalleolar being either the medial or the lateral malleolus. Bimalleolar is going to involve both the medial and the lateral malleoli. And then a trimalleolar fracture is going to be medial and lateral malleoli combined with a distal tibial fracture as well. So just to kind of frame what the next couple of slides and how exactly that's going to work and what what all those fractures really mean if you see them on a report. So just like I said in the other slide, we're going to look at a unimalleolar fracture being either the lateral or the medial malleolus. Bimalleolar is obviously going to involve both of those malleoli. And then a trimalleolar is going to involve the distal tibia as well. So really start to think about what views would I want to see, what images would I want to see, and what would I suspect to see if I think a trimalleolar fracture or the other types of malleolar fractures are maybe occurring with my patient. So this is what a bimalleolar fracture is going to look like. This is an oblique radiograph. So obviously what we can see here is we see that we have a distal fibula fracture. I'm going to circle it. And obviously we have a distal tibial fracture as well. Now notice that we're going to need more than one view here because, as I said previously, a trimalleolar fracture is already going to involve this and this, right? So we're going to see bimalleolar fractures along with a distal tibial fracture. So we need to make sure that we are being aware of what is happening. We also need to be aware of the other implications that can happen. Remember, one view is no view. We always want to do multiple views here. So this is a trimalleolar fracture. What we're going to see here, obviously we see that we have our distal tibial fracture. Now distal fibula fracture is way up here. It's kind of proximal. But what you don't see the distal tibial fracture, the posterior tibial fracture in the oblique view on the left-hand side of the screen. But we turn lateral and we get a nice view of that that posterior tibial fracture. So when we're looking at a trimalleolar fracture, we're going to have fibula involved, tibia involved in two different places. Okay, so there's not three bones involved here. There's only two bones, being the tibia and the fibula, but we're going to have two fractures on that tibia and one fracture on that fibula. So make sure you know the differences between those. Make sure that you can identify those when we come to a final exam. So these are Salter-Harris fractures. We've gone over these a couple times already in the coursework. I'm not going to spend a lot of time on Salter-Harris classification because we've spent obviously other coursework and other class time doing this as well. Just make sure you're familiar with each of the Salter-Harris classifications. Also make sure that you know that Salter-Harris fractures are going to involve epiphyseal plates. So this is what a Salter-Harris 1 epiphyseal injury or epiphyseal fracture is going to look like at the fibula. So what we have here, just kind of use your ABCs. What you can kind of see is that we have malalignment here at the distal fibula. We also have a little bit at the tibia as well, if you consider this whole unit as being a little malaligned. So really it gets kind of tricky, I will say, when we start looking at Salter-Harris fractures. But again, one view is no view. Put this out to the lateral side and we can see a much different story. So that tibia is going to have a lot of involvement here. But these are classified as type 1 injuries at the tibia and the fibula. So now Weber classifications, these are all going to deal specifically with fibular fractures, distal fibular fractures. So a type A is going to be a fibular fracture below the level of the ankle joint space. And what we're talking about with that ankle joint space is that AJS from a few slides ago. So what we're really talking about is that space right in there. Okay, so as you can see, fracture in A or a Weber type A fracture is going to be below or distal to that joint space. In fracture B, if this is my joint space, fracture B is obviously above or proximal to that joint space. So that's going to be classified as a Weber B. Weber C is going to be fracture of the fibula above the syndesmosis. So what we're going to see there is we're going to see a fracture way above the area. So the difference between a B and a C, because they're both above, is that the lateral malleolus fracture is going to happen through the syndesmosis. So in other words, there's going to be a little bit of a fracture that's involved at the space, but the majority of the fracture is going to be above or proximal to the ankle joint space. In a Weber C, we don't see any of the fracture involving that joint space at all. It is way proximal to that. So this is how a Weber A is going to look like on plain film radiograph. Again, what we're looking at here is an oblique view. What we can see is we see the fracture is completely below the joint line. This is my joint line here. My fracture is well distal to that point. This is a Weber B fracture. So just like in the diagram I showed a couple slides ago, this fracture is going to involve obviously our fibula. It's going to be at our distal end, and it's going to involve the joint space. So it's going to have a little bit of a proximal obliqueness to it, but it's going to definitely get into the joint space. So that's another example of a Weber B. This is a really long Weber B. So even though this fracture line goes from here proximally, work at distal, it still comes down into that joint space. So this is still classified as a Weber B just because it does involve. If the fracture, say, stopped up here, then it would be considered a Weber C. So definitely make sure you know the difference between those two. So this is how Weber B looks like post-op. This is where our ORAFs are going to come in. I know a few in the class have shared some pictures of themselves or family or friends with some great ankle fractures and some great ORIFs. So it's as you come across those, please keep them coming, and I would love to see them.